This is medical reasoning, but you can find this is unjust. This is not universal access. So if you just don't have enough equipment, what are you going to do? So I will tell you a short story from Germany. There was a German judge, or there is, she's still alive, a lady who is a judge, but she's very severely handicapped. She can't move, she's totally paralyzed, and she needs 3 people 24 hours to help her do her work and her household and everything, and her personal sort of life, going to the toilet, to the bathroom. So this very handicapped lady, who is a judge or a specialist of law, certainly a very tough lady, because to become a judge when you're so heavily handicapped is really tough work. So she must be a very good law specialist. She went to the law court and complained, the highest law court in Germany, the constitutional law court, and said this was not constitutional, that medical teams decide who should be saved. That was private decision making. It was a profession, and that was something private. She wanted the state to make a rule, and she proposed 2 issues. She said, if I arrive with COVID in a hospital, need life-saving treatment, and there's only 1 bed left and 3 other patients, I have no chance to get it, because I'm so handicapped. I need already 3 people to look after me. They would never choose me. So I think this rule is against me, and I want this rule to disappear. And she proposed that the state should make a rule, either the first who arrived will get the bed, and the second will die. So first saved, first arrived, first saved. Or another rule could be you just you throw by hazard, you throw a penny and see how it falls down and say, well, luck or bad luck. The law court said they would study the case. They didn't decide yet. They didn't even decide whether they will take it on, but they said, we will examine this case. The question is not without any foundation. Now, I think I could give this question to you for some exercise, thinking exercise. Do you think doctors should take decisions on ethical questions like this? Or should you think it should be just first arrived, or it should be the richest person or the poorest person or whoever, or just play games and say, well, this one earned and this one lost, and make it a state rule. So this is really a tricky issue. We had this issue with AIDS when the first good medicine came out, and it was too expensive to serve everybody. And the French government proposed that they would take people by game. And that was an uprise in the country of protest, incredible. And within 1 month, the government was able to find enough money to give the medicine to everybody. Okay. There are economic and humanitarian criticisms on unreasonable therapeutic obsession. Let's take the case of an extremely expensive new cancer medication. They come out from time to time. And there are some medications now who cost millions per person per month. But you may live a few months longer. So the case brought forward, I think it came from Britain. Somebody fought in organizing, the hospital didn't want to treat this person with this very important, very expensive medication, as they have budget problems. And the person was also quite ill otherwise, so not in very good health. And the person mobilized the press. I think it was a former journalist and the media, and they fought a battle with the government, and the government withdrew and let him have this very expensive treatment. It costed a few million euros, and 5 months later the man was dead. So the question behind this is, what ethics should we apply for these things? I mean, doctors would like to give him this medicine because they always want the patient to live, and they're scientifically interested. They say this is also trials. We will see whether this works. We need to have trials. So there is a scientific argument to say this man should have this very expensive medicine, even if we can't save him, but we will study on him what it does and what it can't do. And the other reason is, but with these many million of euros for this man to live 5 months more, and probably very painful months, We could have done so many other good things for population health. We could have saved so many children. We could have saved so many other ill people. So there's a problem about the good use of money. And the other argument is clinical and scientific. So interesting question. Yeah, so to sum it up, you have medical decisions of clinical interest versus budget regulations and the health needs of the majority. A majority of people against one case or one man, one person. Attribution of organs for transplantation. Very different things in very different countries. The rule in Europe, in most countries, is you have waiting lists which are made with medical data. So if you need a new heart, for instance, your case will be described exactly, and then there's a national register, and they will need a heart of this and that type, and compatible like this and that. And you will be put on the waiting list according to your hope of survival. What will it bring to you? Will you get better? And also your state of suffering. Are you already urgent, or can you still wait? All this is put into some, lots of information, which are now treated by computers. And then there's a waiting list, and you have to wait. You cannot buy an organ in Europe, even if you're a millionaire. You have to sit on the waiting list. And many people would like to put all their fortune in it to jump the waiting list, but in most countries, at least in France, it's impossible. So you have waiting lists according to medical conditions. But we have in Grenoble a very interesting PhD going on, where a young man who is very interested in artificial intelligence and political science, he's investigating an innovation which they introduced in the transplantation business, in the transplantation sector. These waiting lists are more or less, they are made by doctors, by specialists, with all these criteria. They make the criteria, there are national commissions for that. And the doctors know how it works because they participate in doing this, in making these criteria. And now there is, because this is a lot of work, they have artificial intelligence and they run programs. This is an experiment. In several hospitals, they run innovative programs to let artificial intelligence work out the waiting list. And the results are very interesting. The results brought forward much more social equity. So if it was the waiting list with all these criteria, with all these honest people, with all these good commissions working it all out, but somehow manually, and the doctors know what's in it because they know the criteria, every doctor will try to present his case, his patient, in a way that it fits best into the waiting list, to jump a little places. So the doctor will write the case about his person, his patient, a little bit according to what he knows about the waiting list, the criteria. But if you put all the data just into artificial intelligence, it will bring you out a slightly different waiting list where you have less well-positioned patient in top and more poor and socially badly situated patients more on the head than in the manual working list. So even if all the ethical medical criteria is respected, there's always a bias, a social bias. So equity is really a very difficult subject. And the question behind is, would you like, if one day you need a transplantation, would you like to be sorted out by artificial intelligence or rather by human beings, doctors? I let you think about that. For me, all this is part of a broader conception of universal access. It's not just a hospital near a poor quarter in New Delhi or in Berlin with open doors. There's much more behind. This is what I wanted to tell you. In the same way, for ladies maybe are interested, gender issues. I took the reproductive health in Europe. We have lots of ethical rules about who can have artificial fertilization, sperm donation, and all this. So a few important points that stand out. Surrogate motherhood. There are countries in the European Union where it is allowed. I think Spain is one of them, if I'm not wrong. And then in the periphery of Europe, on the eastern border, in Turkey, Belarus, there's a real big business about this surrogate motherhood. It is forbidden in France, it is forbidden in Germany, and forbidden in some other countries. I don't want to name the countries because I didn't check it all, but just take it. This is not a European policy. Everybody talks about ethics, but some countries allow this and others don't. France is very strict. You won't have surrogate motherhood in France, totally forbidden by law. So, but other countries do. Abortion. Again, the French case I know best, so I will take the French case. We have in the European Union now a sort of consensus that it is a woman's right to have an abortion. And we don't ask the man's opinion. If a woman, even married, wants to have an abortion, we don't talk to the man. The woman decides what she wants. This may shock some other countries. The man can come with her, he can give his opinion, but the people who, if there's a no, they make sure that the no is the woman's no. They will see her alone and try to talk to her and that she can express herself freely. So taking France and some majority of countries in the European Union, abortion is free of charge. It's a woman's own decision, as in most European countries, except Poland. Poland had authorized years ago when they joined the European Union, they authorized abortion, and now with their conservative government and the Catholic Church behind, they forbid it again, even in cases of rape and family rape and danger for the baby and the mother. And this is one of the big points of dispute between the European Union and Poland, is abortion. Contraception. In most countries in Europe, it's totally free. The health insurance pay for it. It's accessible for all. And in many countries, even under majority age. So if a girl who is 16 or something wants abortion and the parents don't want to know, there are ways for her to get it. So all this is very free and very morally accepted. A medically assisted procreation, for instance, in vitro fertilization, with or without sperm donation. There are different legislation all over the European Union. In France, this is what I wanted to tell you. It's a nice country for women. In France, since September 21, there was one PUMA reform of the health insurance, and there was this year. Now it's open to all women and paid totally by the health insurance. So you can get in vitro fertilization with or without sperm donation if you are a single woman or if you are lesbians or whatever. And that was not possible before September 21. So this is very new, and this is the influence of President Macron, who always said he was a friend of women and he wanted to do laws for women.